So this this first slide has its picture, and since it may be the only one, I'll tell you about it. This is a picture from the floor of the Rift Valley in the middle of the very extended drought. And this was in 2005. And everything for miles was brown and gray except this one very green acacia tree, testifying to the power of a taproot, which we should all be able to testify to.
Right.
Are we supposed to be seeing the picture?
You were seeing the picture, weren't you? I'm looking at the picture.
Oh, that little round thing in the corner. Okay.
Yes, that little round thing in the corner is a picture. There was a picture on this slide too, but I took it off because I think it was probably the issue. It flashes at you and makes you very uncomfortable, which is kind of how I wanted to start. But I don't get to flash my seizure picture at you and make you uncomfortable. So we'll just start with what seizures are. So seizures are both simple and complicated. They're really quite simply abnormal electrical discharges. Excitatory neurons go into a feedback oscillation. They fire repeatedly. And what you see when a patient has a seizure and what a patient experiences really just depends on where in the brain that activity occurs and whether it involves both sides of the brain or just one area. Let's see, I'm not expert at this moving the slides yet, so give me a second. Okay, so the abnormal electrical activity can start in one area. Often this is a small area that's not completely normal brain, a scar or an area with gliosis or an area with abnormal neurons, sometimes from development and sometimes from something that happened later. But that area sits there pretty much the same all the time, and why sometimes it decides to generate a seizure and the rest of the time it doesn't is actually a complete mystery. I have no idea why a seizure focus only generates a seizure sometimes once a year, sometimes once a day, and anything in between. And it's really quite a mystery what generates that seizure at that moment. There are things that we know of that increase the possibility, the probability, like a fever. But the actual why of when just isn't known. In contrast, a seizure can start all over all at once. Well, it doesn't actually start all over all at once. Probably what happens is that seizures that start all over your cortex all at once start deep in the brain and then flood the cortex all at once. So they seem to start from the perspective of what we experience and an EEG all over, all at one time, all at one instant. Or they can start in one focus, one small area, and spread quickly to more parts of the brain. That's really your only options. Okay, so if a seizure starts and stays in one area, it's a focal seizure. What happens then depends entirely on where that activity is occurring in the brain. We think of this most typically, particularly people who don't think about seizures very often, as a motor event with one hand shaking or one leg shaking. But it actually can be any number of odd things: an unexplained odor, an odd taste, a disturbing feeling or emotion. There's even seizures that just produce an odd kind of creepy laughter, depending on where that focus of abnormal electrical activity is. seizures can, as I just said, seizures can start abruptly all over the brain, but that's actually not what happens. It's just that this generalized seizures occur all over the cortex all at once. They probably originate in some area of the deep brain. And what's remarkable about them is that both sides of the cortex are suddenly involved at the same time. So there isn't any warning, and there's a sudden loss of consciousness, because it's when both sides of your brain are involved in a seizure that you lose a sense of consciousness. So what a person experiences can be different, and these can be different events. With generalized seizures, we describe them by, again, what we see the person doing. So I've listed the typical generalized seizure that you can see. The simplest, probably most commonly observed by people and very common in children as a seizure disorder are absence seizures that have almost no motor involvement. There's really just a loss of cognitive awareness. And often it is fairly invisible to the people around, with maybe staring, but often not a lot of change at all in motor processes, but the brain is just not working. A tonic seizure involves stiffening of the body in an extensor posture. Clonic seizure involves rhythmic contraction and relaxation of the flexor muscles. And the classically described grand mal seizure was actually the very typical tonic-clonic seizure. And what happens is that you have a brief tonic phase where the body stiffens because the diaphragm contracts. There's an exhale of air which causes a sound to occur, and people notice that. And then that's followed by clonic activity. We've gotten away from the old language because it's not very descriptive and it doesn't help us with treatment plans and predictions for what's going to happen next. Atonic seizures are typically very brief events, but they involve a complete loss of muscle tone and body posture. And these are the children that you see running around in helmets because if you can't control those seizures, they aren't safe because they can have them happen at any time and they suddenly drop to the ground, and that's not a good thing to do if you're up in a tree. So it isn't even a really good thing to do if you're standing on a sidewalk. So but they're actually probably one of the more dangerous seizure types, even though they're extremely brief and they often don't even have any follow-up post-ictal state. Okay. So the third type of seizure is not really a different type per se. It's a focally started event where the focus doesn't stay focused. The activity spreads, and so that electrical activity that had a single location of origin is not contained. Children typically, if they have focal events, they have these secondarily generalized seizures because their brains are not capable of retaining the abnormal electrical activity in one place. And these go by partial complex seizures or focal seizures with secondary generalization. This actually means the same thing. And again, what happens is first you have a focal event, the same as before. It can be brief, but it will start with one place, eye deviation, or one hand or one leg shaking, or some sort of unexplained, again, odor or taste or sensation. And then fairly quickly you'll get a generalized event where you have shaking of all four extremities. Now this shaking doesn't have to be equal. you're just seeing involvement of all extremities. And there's a number of reasons why one side may shake more vigorously than another. And that's that's what we see, but it's no different than saying whether or not when you cough a couple of times, or you cough 4 times or 8 times. It's it may seem important, but the pathology doesn't have to change. Okay, so what causes seizures? Seizures always have a cause, but we are not always smart enough to figure out what it is. I think it is helpful to think of seizures as being what I call either intrinsic or extrinsic. Intrinsic being an event provoked by a feature of the brain itself. And extrinsic as being a response of the brain to something external. And then, of course, your third option is that something external changes the brain, and that subsequent damage would go forward in time to cause what then I would consider intrinsic seizures. So that's the only way that it loops back on itself. Yay, pictures!
Very good.
So this list of causes of seizures is not exhaustive, but it's a really good place to start, and it will make a big difference if you think about even just this restricted list when you're in resource-poor areas or any kind of developing world situation. This short list is the things you can change, the things you can impact, and an approach to treatment for the things you can't change. And that's kind of how I want to talk about it. So we want to look at infection and metabolic and toxic causes, tumors, traumatic, congenital, developmental, and epilepsies. Okay, so I want to start with what I'm calling extrinsic causes. These are illnesses with associated seizures. And the seizures can be effectively treated until the illness resolves, and then not treated if all goes well afterwards. I like this intrinsic extrinsic. It's the primary causes of seizures in developing countries are seizure disorders in developing countries are actually secondary to preventable extrinsic events that didn't go well and resulted in brain diseases, damage, and then you have a lifetime seizure disorder. So it's really, really important when you see seizures, particularly outside this country, to always think about whether or not you're dealing with something that you could make transient. And when someone is sick and they come into a mobile clinic, acutely sick, and they have seizures, those seizures are also a clue, because not everything causes seizures. And it may be that that you don't have enough testing to determine what their underlying illness is, but in the presence of seizures, you have actually not only something to deal with, but you also have another piece of information, because whatever it is they have is able to cause seizures for some reason. So we can look at the common infections associated with seizures and keep in mind that either the bug, the bacteria, the virus, the bug itself, or the parasite, either the bug, the electrolytes, or some toxin has to be around to cause seizures. Just being sick by itself, just having sepsis won't cause seizures alone. Let's see. Okay, so I'm going to give you just some examples. So this is a boy. I'm sitting here on the other end of a phone. Will somebody speak to me and tell me that you're all there and some of you are at least awake?
I'm still here.
Yeah. Pam, I'll even go one step further. I'm just going to back you up a second and comment about, you just said that sepsis alone. Can you just make a quick comment about like fever-induced seizures in children that, that have infection, systemic infection?
So you can certainly have febrile seizures. That's one of your causes of seizures during an illness. Then the fever itself is causing the seizure.
Okay.
But just sepsis won't. It has to have help. And children won't have, like, if they come in with that high fever and they've had those high fevers before and never had a seizure, then you have to let go of that possibility. It's not the fever by itself. Still have something else causing it. Seizures aren't just a common denominator of every bad thing out there. They really are only a common denominator of a relatively restricted subset of things. Thank you all for your reassurance that I'm not just talking to an empty phone line. I appreciate that. Please do interrupt me with questions. I might notice the chat box, and I'll definitely hear you if you say something, and I'm happy to take questions as I go along. So this little boy presented to Kajabi Hospital, actually, sick. He had a vague 2-week history of not being quite right, decreased appetite, tiredness, not quite himself. He was brought into the hospital because of generalized seizures over maybe less than a day, repeat events. He had maybe he'd had fever, maybe he'd had a cough. The history was extremely vague, and basically he was having generalized seizures when he came into the hospital. He did have focal neurological signs, but an altered state of consciousness. And on chest, the only thing we could find evaluating him was a consolidation on chest X-ray. But pneumonia doesn't cause seizures. And he was getting worse very fast. So we actually aggressively treated him for tuberculosis, and that's what he had. And if we hadn't, I'm quite sure we would have lost him. He was deteriorating painfully quickly. And instead, oops, I just tried to change the slide on my computer and it didn't work. There we go. Instead, a couple months later, we had a healthy little boy. This was one of the first children I saw when I was over at Kajabi, and the very first time. And it made a strong impression on me that it was really, really important to think about where you were and what could be going on and what you could change the outcome of. This little girl was not so lucky. She lives in a malaria endemic area, and as an infant she got sick with seizures and high fever. Unfortunately, this is a very typical story for either malaria or meningitis, and she was treated for malaria several times, not treated for meningitis. She ended up blind, very cognitively impaired, and with a permanent seizure disorder. And it's really important to always consider that just because something is common, it doesn't protect you from something else. Meningitis is very rarely treated in malaria endemic areas, and it still exists, and it still causes all the same problems. And I cringe whenever I hear of a child being treated for smear-negative malaria, because I think that the first 3 causes of their smear-negative malaria is probably meningitis when associated with seizures.
Now, Pam, this year is a particularly heavy year for meningitis that's spread throughout the Sahel right now.
Yeah. Do you have any idea what type?
No, I don't. I just tracking that on a tracking mechanism.
Most likely meningococcal.
Bacteria.
Yeah. The cephalosporins are really available. So there really is no, one shot a day will do it. You don't even have to admit them to the hospital. And so there's just not a good excuse for not treating any child who you can't demonstrate malaria for meningitis if they come in with high fever and seizures. And I don't think I could say that too many times for my own comfort anyway. This is another something to keep in mind. This is actually neurocysticercosis in a young woman around 30 years old. She was diagnosed with a brain tumor and told that she needed surgery. They couldn't afford surgery, so she didn't have it. About 6 months later, her husband showed up with her CT scan, not her, but her CT scan, to see if I could help her with her seizures. And he handed me the scan, and this is not a brain tumor. This is cysticercosis, and it's very underdiagnosed. I believe it's very underdiagnosed in Africa. There's some other people who actually also believe it's underdiagnosed. It's, however, the most common cause of seizures internationally in adults. It should always be considered because it's extremely treatable, and the seizures are treatable, particularly if you recognize it. And this woman, we treated her and sent her home on carbamazapine and a new lifespan because she thought she was dying of a brain tumor. And that actually makes a really big difference too. It maybe didn't change medically what was going on in her head, but it changed a whole lot emotionally what was going on in her head. Besides, it was so much fun. Totally. Okay, so I want to look again. We'll go through the differential again, but I want to go through just some examples of what I'm considering intrinsic causes. Intrinsic causes are more likely in children. When you see an adult with what you're thinking are structural seizures, search around for that history. A lot of times, if there's only a few events as a child, no one ever mentions them, and so you may have to really search for a history. So you can see new seizures in an adult that are caused caused by congenital events, but you should be able to find some evidence of it from early on. This is one of my favorite examples. A young lady with seizures on a huge frontal encephalocele who came in because of her seizures, never expecting that she could get her encephalocele treated. And one repair and some carbamazapine later, and you get this totally lovely outcome. Not all malformations, unfortunately, are that easy. Hydrocephalus, even treated with a shunt, is often associated with seizures. Now, these can be much harder to treat. Cerebral palsy, you've heard me yammer on about cerebral palsy before, at least some of you have. It's too broad a diagnosis medically in any case, but in the developing world, it's a broad enough diagnosis so that it doesn't really have medical utility. Whatever causes the motor issues can certainly cause seizures, and honestly, the more broadly the diagnosis of cerebral palsy is applied, the greater the likelihood that a child that comes in with that tag will have seizures. The little girl I showed you previously with meningitis and subsequent disability was presented to me as cerebral palsy. It is the lay diagnosis for a disabled child that's wildly prevalent. The seizures, the thing to keep in mind is that the seizures in a child with CP will be much easier to treat in the children with better cognitive function, largely because it will reflect a more functional cortex, and that more functional cortex is more likely to have controllable seizures. And then this child is just to say that all the disadvantages of resource-poor areas in developing countries don't actually protect you from the bad things that we see in the Western world. This child was born fine, needed a shunt late in infancy for unclear reasons, other than needed a shunt, and then started having infantile spasms, and uncontrolled spasms went on for a couple of months, and really devastated him. His mom, I have a wonderful picture of his lovely mom. His mom is educated and very attentive, and we communicated at length by email since I met them a couple of times. And we've tried lots and lots of things, but he's about 2 years old in this picture. He's blind. He's not doing much responsive, and it certainly isn't for lack of trying by either of us. So, bad things are still bad things, and they don't get better just because they aren't as common among the things that you see. When someone comes to your attention for the first time with seizures, it's really important in developing countries, way more so than in the U.S., to consider if there is a treatable cause for what's going on. You want to think about whether you have an acute illness, whether you have a chronic illness, and whether you have a known neurological disorder. If you have a known neurological disorder, one of the things on the top of the thought process for me is why now? Why am I seeing this child who supposedly has had seizures for years now? Other than I heard there was a neurologist at Kajabi. Is there something going on? Because pre-existing seizure conditions will suddenly get worse in the context of any illness, any fever, malnutrition, any stressor to the body as a whole. Anyone who gets headaches knows that their headaches get worse when they're sick, and the same is true for seizures. If a child is sick, their seizures will get worse. So they may have an underlying seizure disorder that nobody's really dealt with, and then they get tuberculosis, and nobody actually knows that. Everybody coughs in the village, but now they're having seizures. That is certainly a reasonable scenario for a child that comes in all of a sudden. And so thinking about what acute illnesses, which we're about to go through, but also thinking about what chronic things could be going on and what the background is that the new event is occurring on is really important with these kinds of assessments. And of course, you don't have a lot of tests. You have to actually think of things in order to see them. So then the top 90% of this list is when someone does not have a seizure disorder, but they come in with seizures. So then if you're looking at an acute illness and you're thinking, and you want to think about infections because you have some reason to think about infections, like you have a fever, or you have diarrhea and vomiting, or they're complaining of headache, or you have some change in mental status, or lethargy, or cough. Then your disease culprits have really been narrowed down once you have a seizure. If you think about the GI system, so there's two reasons why you can have seizures in the context of a vomiting and diarrheal illness. One is the disease itself, and two is the metabolic impact of the disease. So the two GI diseases that cause seizures by themselves, and so you may see them really early in the course of a diarrheal illness before you really should have a metabolic cause, are Shigella, which everyone knows, and rotavirus, which is not a common cause of seizures if you look within how often does rotavirus cause seizures. But when you look at how often rotavirus is the cause of diarrhea, then the small percentage of children who get seizures from rotavirus become a relevant number. What happens with rotavirus is that particular strains of it will cause seizures, and so you will see a flurry of them as a particular strain of virus goes around an area. And then you might not see it again for months or even a year or so. It's not that rare. But once you see one, be alert to another, because particular strains clearly are more seizure-producing than others. Once you've had a GI illness for anything more than 24 hours, with profuse diarrhea, then you are vulnerable to seizures from the electrolyte imbalance, glucose, magnesium, and calcium levels. And so that nutritional stabilization is really important. And you won't fix, if you have an electrolyte imbalance, you won't get rid of those seizures until you correct the electrolyte imbalance. Let's see. So sepsis. We already talked about that. Sepsis alone doesn't cause seizures. Certainly, if a very young child is just presenting with a high fever, you can certainly see a febrile seizure. But I think that at some level, febrile seizures are overdiagnosed in hospital settings, because they typically, in the resource-poor areas, by the time a child gets into the hospital, they're done with febrile seizures. You might see them in a clinic afterwards, or you might, but on an emergency basis with ongoing seizures, you shouldn't have that from febrile seizures. Febrile seizure is typically as the fever is going up in the beginning of the illness, and so in an area where you call 911 and they hop in an ambulance, you see them all the time. In an area where the first seizure event doesn't even generate medical care, you don't typically see febrile seizures. So it needs to be, once you're in the developing world, it needs to be in a region that has extraordinarily good access to medical care in order for that to be high on your list. So I actually don't put it high on the list, possibly because to me, if you see it, it's pretty obvious, and it should never be the first thing you think of. Taking care of the illness under those circumstances should really always be the top of the list. Let's see. Oh, I'm sorry, I lost my train of thought. So we talked a little bit about the chronic illnesses. I have HIV, toxoplasmosis, and CMV on here because they can cause brain abnormalities when they have vertical transmission, and so you can have infection causing really a chronic seizure issue. And so it's something to think about, and it's also something to think about because there may be others in the family where the problem can be prevented if recognized. We talked about metabolic disturbances. Sometimes you'll see seizures from metabolic disturbance in resource-poor regions because people are at such nutritional and fluid edge. They don't have the reserve, and so getting lost or heat stroke or no money for a couple of days can actually put someone into a metabolically related seizure because they're so fragile to start with. And related to that is my least favorite painfully prevalent disorder, which is alcoholism. You can get seizures from alcoholism in many, many circumstances. Withdrawal seizures, nutritional and metabolic crisis with seizures, and trauma-induced impact seizures from a fall with alcohol. So alcohol is probably the most common seizure associated in an adult who's not had previous events and isn't otherwise sick. And unfortunately, sometimes they come in unconscious, as you all probably well know. And then speaking of trauma, I just have one comment to make on trauma. When people leave the U.S., they seem to forget about gravity. Gravity is your friend, and gravity is still your friend in South America and Africa and Asia. And gravity is a friend of head trauma. I have been preaching elevating heads of beds, and it's stunningly rare to see it utilized. If someone comes, you see someone with head trauma or unknown trauma that could have head trauma because they're not telling you what happened, then there isn't any reason not to elevate the head of the bed and monitor fluids and produce supportive nutritional care. That doesn't cost anything, and it's as well documented as anything else we do for head trauma. So I just want to make a plug for a very, very simple attribute of utilizing gravity for the first of two times we'll talk about it. I have preached this and gone back and revisited and still seeing the same treatment. Trauma victims are all laid flat on whatever surface, and they really shouldn't be. Okay, so evaluation of seizures. In summary here, I have, even in a resource-poor region, sufficient evaluation is available to treat the extrinsic causes and prevent chronic disability when it's considered and recognized. And the more promptly you recognize and treat a disease causing a seizure, the less permanent the seizures will be. This is just true. The longer they go on, the longer the disease is allowed to be active, the more potential damage you have, and the more likely those seizures will last. If you can treat an abnormality and the seizures resolve with treatment, then a patient doesn't need to be treated for seizures. They don't have a seizure disorder. They just had an illness that caused seizures. So let's see. So what do I think you can do? I think that leaning on EEGs is unfortunately too common and actually not helpful. Most seizures that you're going to be able to help in the places that we go in the developing world can be diagnosed without an EEG if you have a good history and an exam. Honestly, I would rather have them than a bad EEG any day, and you never know when you're getting a bad EEG because the quality is really important and really variable. It is also really important to determine whether or not you really have seizures. The seizures that are not seizures do not respond to anti-epileptic drugs. Those drugs cost money and they won't work. So it's really important to determine that those spells are seizures. All unconscious events are not seizures. Cardiac ones will kill you. The seizures won't. A lot of spells in children are not seizures. It's important to figure out what you're dealing with, and the best way to do that is really by history. You can run a treatment trial, but if you do that, you should think about the fact that you're doing that and you're thinking about it that way. learning about the spells, when they started, how long they've been going on, how many of them, how often, who's seen them, who's never seen them, why have they never been seen, what circumstances they happen under. All these things are really useful and often very difficult to get in a population that has, at least in Africa, where there's such taboo and such social issues associated with seizures. That good history can be harder to get than the EEG, and it needs to be done really carefully, because a rewording of the same question will result in a different answer, and once you determine that, then you realize how difficult your history is going to be to get. And so then you need to talk to other people, and you need to try to get the rest of the medical history and fit it in place, and all of those things. And all of that will give you clues as to how to move on and think about treating such events. It's very important to get in children to get a developmental history to find out if you're dealing with these events in the context of a normal development or the context of a really abnormal development. And a lot of times you have to take your exam, realize there's something wrong, and go back and retake that developmental history. And so the developmental assessment can go back and forth between history and exam, and try to understand, the discrepancies until you can really figure out what might be happening. And if nothing else, that really good history will limit the number of tests that you feel you might want someone to spend money on in their resource-limited situation. Medications are really important. Other medications that someone is on will not only tell you what illnesses they haven't fessed up to, but they'll also tell you what side effects they might be experiencing, overdosing, underdosing, and if they're on medications for seizures, then those medications taken erratically can be causing seizures all by themselves. Let's see. So, this really is a summary. If seizures are secondary to an acute event, then you stop the seizures by treating the cause. If seizures are secondary to a chronic cause, then think about what acute changes might have precipitated seizures, medication changes, secondary infections, nutritional issues, drug interactions. Some of those drug interactions can be things like another drug they went on for another disease that decreased the levels of their seizure medication. So those things can be actually really important, particularly in HIV areas. If seizures are due to intrinsic causes or chronic stable condition, then consider anti-epileptic medication. And then you're directed at the type of seizure event independent of the underlying cause. We'll go through those quickly. So treatment options are limited, but really a vast majority of seizures can be thoughtfully cared for and controlled. Different types of seizures respond better to different medications. Focal onset seizures respond to one subset of medications, and generalized seizures respond to other ones. And this is when your history, particularly other people's history, or if someone can tell you that they remember their handshaking before they lost consciousness, these things are really easy to help you figure out whether something started focally or started generally. And that's all you have to figure out is how it started. It doesn't matter whether or not it generalized after the fact. What matters is whether or not there was an initial focus or not. And the options that are widely available, at least in Africa, really are limited to phenobarbital, carbamazapine, phenytoin, and valproate. And it's also really important to keep in mind availability and cost in the region that you're in. Phenobarbital is usually available. I have yet to be anywhere where it isn't. I haven't even heard of anywhere where it isn't. And it is on the order of a penny to a few pennies a day. It also has a really long half-life and is really safe to not be able to get for a few days. And then, or weeks, or whatever it is, and then you get enough money to get some more. And that never presents a safety issue. other than that the seizures might come back. Carbamazapine is another excellent option. It's a better drug. It has less side effects. It's still pretty affordable and pretty available. It runs 5 to 10 cents a day. But it is more dangerous to start and stop. And the sudden restarting of the previous dose after a sufficient break, which shouldn't really be anything as little as a few weeks, will cause significant side effects, and sudden stopping can actually precipitate seizures. So you need to feel some sense that you have some sort of a reliable situation, or at least there's a reliable intent to utilize carbamazepine. If you have a really erratic situation, it may be unsafe. Dilantin has similar characteristics. It's about 20 cents a day, 10 to 20 cents a day, but most adults it runs around 20 cents a day, and is an excellent drug in adults. Valproate is a great drug. It is less consistently available. Some places that it's available all the time, it isn't actually available all the time, and so someone who wants to stay on it will need to show up at the pharmacy every day until they can replace their prescription, and it really requires some investment on the part of the user, and it costs somewhere between $1 and $2 a day, as opposed to pennies, and this can be really prohibitive. Yes, that's true. Okay, I'm just going to run through some highlights of these 4 drugs really quickly. There's nothing exhaustive about this drug information. It's just a place to start thinking about them. So phenobarb, as I said, has an extended half-life, once-a-day dosing, which is great in difficult life circumstances, very safe, and I tend to use it in children under 3. It really is the drug of choice in children under 2. And then you can look at the circumstances between 2 and 3. Maintenance doses are typically not aggressive enough. The CNS depression that you see is usually acclimated to if you give the dose at nighttime and you give it once a day instead of twice, which seems to be common but not necessary. Then you get less depression because it gets slept off. It is also the drug to give when someone comes in to a mobile clinic or any sort of a clinic situation where you have an acute seizure event. You just give phenobarbital and then you can think later. You can load it IV, PO, NG, any way you like. 20 milligrams per kilogram, and then just keep giving doses. Your only side effect is respiratory suppression, and that will not happen prior to 40 milligrams per kilogram, and it is unusual if it's given slowly. So if you're giving 5 milligrams per kilogram additional doses until you get seizure control, and you give them every couple of hours, you should get seizure control long before you get respiratory suppression. And it may be the safest drug when you have children with seizures on a lot of HIV drugs. There's a lot of interactions. That's a lecture unto itself, and I'm not getting into it, but it is definitely something to consider in HIV regions, which drugs you can use. Carbamazapine is a great drug. It will, however, make your generalized seizures worse. So if you have a child with primary generalized seizures, or an adult with primary generalized seizures, carbamazepine is not a good drug. So therefore, if you have a child with focal seizures and an absence-type seizure, you can't use carbamazepine, and that's really problematic because of the limited number of drug options. It's broken down by your hepatic enzymes, which have to build up. So if you start carbamazepine at the maintenance dose, it will fail as a therapy, because if you start it at the maintenance dose, it will be toxic initially. If you start it at a non-toxic dose, and don't go up, then you won't have enough of a level to protect someone. This is really hard in an area where you might see someone once and not see them again. So the best way I have found to do that is to decrease the frequency. And so they're always giving the same amount, but you just give it once a day. 5 milligrams per kilogram is a good place to start. You give it once a day for 3, 5 days, whatever. 3 days is a minimum, and then you give it twice a day, and then you can go to 3 times a day. Or you can go to twice a day, and if you have the luxury of a phone call or a visit or an email, then you can see if you need to go to 3 times a day. But if you start at a full dose, which is apparently very common, I see it a lot, then you will hear that they failed it, and they failed because the toxicity is too much. And we in the U.S., there's plenty of variations on carbamazapine that have long half-lives, but the version available in the third world is fairly short-acting, and you may have to go to 3 times a day, every 8-hour dosing. And the leukopenia should be watched for. It is not always an option to watch for it. If you have that luxury, then you should be checking CBCs every 6 months. Valproate, marvelous drug, works for all seizure types, multiple seizure types in the same person. You can start with a full dose, although there's some toxicity perceived. It's usually not problematic. And the only thing about the pancreatitis is it's fatal if you don't stop the valproate, so everyone should know that. And phenytoin is a fabulous drug, but it is not good in children. It's great IV, but it doesn't have reliable absorption, and so you go from toxic to nothing, and it's very rapidly metabolized. And the side effects of the rash and gingival hypertrophy in children are really problematic. So it's a great drug in adults, but not in kids. And I have to go through this because it's really important to me. If there's anyone that's listening who actually doesn't know what to do when someone is seizing, I want you to hear it without being traumatized by a multiple choice question where you have to fess up to having never seen someone seize and not being sure what to do. So I'm just going to tell you, and if all of you already know this, then that's just fine. You can just bear with me. The first time you see someone seize, it's pretty scary. And so you should expect yourself to have a rapid heart rate and get nervous. So stop and calm down and breathe, because it only feels like the time is racing. It's really just that it's scary to watch someone seize. And then stay. Don't leave for help. You can call for help, but don't leave, because all a person who's seizing needs is you. You, whoever you are, that's all they need. The seizure will pass, and the only thing they need is for you to protect them while the seizure passes. You need to breathe, and they need to breathe, and that's really all it is. It's airway, 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 airway. Your airway, breathe, calm, breathe, breathe. And then you make sure they are breathing. And you do that by using gravity again. It's my second plug for gravity. Gravity will bring everything out. It will drop the tongue forward, and it will keep the trachea clear from vomit and secretions and obstructions if you can keep a person face down. Now, if you have a child, that's easy. You sit down on a bed or a couch or a chair or anything you can find that lets you sit stably, and you put the child face down across your lap. And you can keep them, even an older child, pretty stable that way until they get closer to adult size or bigger than you. And you are keeping their face up off the ground but face down. So everything comes out and the tongue drops forward and all the anatomy is in your favor. If you have an adult that is bigger than you and you can't manage that, then you have to do the maneuver between on their side and face down. I prefer something soft that you can put across under the shoulders and still try to basically keep somebody face down. The most and only thing you really have to do is keep your airway open. Seizure will almost always run its course. And the reason that people die during a seizure is because their airway gets obstructed. That's why. So that's what it's all about. And if you leave to get help, They can die of their seizure while you're not there. If you are there to keep their airway open, that's all a seizing person needs. And that's it. That's the end of my preaching.
All right, that was awesome. What about questions? Does anybody have, you can ask, now's your chance, you can ask everything and anything about seizures. We are limited for time, but we will definitely take a top 2 questions. How about that?
Thank you, Kelly.
I will ask, can you make a comment about status epilepticus?
Oh, I didn't put it in because it put me over 30 slides, and I knew I would go too long. If you want to talk on status, it's probably better another time. But if you have a quick comment, then please just make it. But status is treatment of it in resource-poor areas, and when you don't have code carts around, there's a whole, it's an interesting discussion. I'm happy to have it, but it's not a 30-second one.
No, it's not. Okay. Well, we'll save it for a rainy day. I have another one. I have plenty, but can you just make a comment? What about someone that is, there's a differentiation between simple and complex seizures? Can someone talk and have a seizure?
Okay. So focal seizure, your consciousness, by definition, if it's a focal seizure, then your consciousnesses and your cognitive responses are not impaired. Once your cognition is impaired at all, then it's a partial complex seizure or a focal seizure with secondary generalization. Now, that does not mean that you're completely unconscious. It may be that you're confused and don't know what's happening, and other than the general confusion of why is my arm shaking, but you may not know who you are, you may not recognize the person with you, you may walk in circles, you might do all sorts of really strange things. That's involved cognition, but it's not unconsciousness. So yes, there's a whole large range, but all of that is considered partial complex seizures. Once your cognition is involved at all, by definition, it's not a focal seizure.
Right. Complex means it's generalized.
Well, it means that it means, at least in theory, that it's involving both sides of your brain and impacting your mental status.
Right. So you use complex as opposed to simple, right?
Simple focal, so you can use that language. There's a lot of language. I try to minimize it, but simple focal will go together and partial complex will go together.
Right. Yeah. Okay. All right. Anybody else? Last second question, and then we're going to make a comment or two and close in prayer. Yes. A question? Go ahead. Go ahead, yeah.
Oh, hi. My name is Brandy Sullivan. I am a first-year student at Wake Forest. And I just had a question about the absence seizures. We had learned that ethosuximide was the drug of choice for absence seizures in children. And I just wasn't sure how readily available it is in developing countries.
Yeah. So Wake Forest, you're in medical school?
Yes, ma'am.
Okay. So actually, so that is certainly that was the historical party line. At this point, I would say that I'm surprised it's still being taught that way because the first line drug is valproate, not ethosuximide for absence, unless your child is really young. But ethosuximide isn't available. So it isn't widely available. I don't think it's actually available at all outside of the more developed countries. And even in the U.S., I honestly haven't used it in years because valproate is so good at absence. And it's rare to have someone with absence who's, usually by the time they're getting true absence seizures, they're, 3 years old or close enough so that you're comfortable using valproate. And then there are some other of the newer generation drugs that are in debate. But I would say that ethosuximide is kind of in disuse, but it is not an option in developing countries. It's just never been made available. So so even if it was a drug of choice, you would have to use valproate. That's the only option. And then you cannot use carbamazapine. That is one of the circumstances where you will make things much worse if you give a child with absence carbamazapine. So if you cannot give them valproate, unfortunately, sometimes you have to give them phenobarb, which is not a good option.
Right.